All right. Hello, everyone, and welcome to this free CE research webinar, Massage and Pain with Whitney Lowe and Doug Nelson. My name is Adrienne Asta, and I am privileged to be serving the industry as the president of the Massage Therapy Foundation. And our vision at the foundation is to keep massage therapy evidence-informed and accessible to everyone. So I want to personally thank Whitney and Doug for giving a lot of their time in order to make this presentation and webinar happen. Thank you, Whitney and Doug. I'm really thrilled to be able to present this to our audience today and then in perpetuity. So um, Doug and Whitney have far over 80 years of collective experience. Whitney is the founder of the Academy of Clinical Massage, and Doug is the founder of Precision Neuromuscular Therapy Seminars. They both have been very prolific in our industry with writing articles for various publications. And they have such an incredible presentation for you today. You can earn 1 CE at the end of this webinar, and we will have details for that at the end. But in order to get into all of the wonderful stuff you have presented, I'm going to turn it over to Doug. Thank you, gentlemen, for being here today.
Indeed.
It's a pleasure. Whit, if it's okay with you, I'll just kind of start out. And
Let's do it.
yeah, so let's start. When we're talking about pain, the first place to begin is just with the definition. So this definition is from the International Association for the Study of Pain. And while this is very simple, I'm telling you, the amount of thought, the debate, the input that went into just creating this simple sentence was legion, let me tell you. So an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential damage. I realize that sounds like it was written by an attorney, but in the end, it's actually rich with a lot of content, a lot of which we will explore today. Let me point out maybe just one thing: an unpleasant sensory and emotional experience. It doesn't say or, it says and. So by definition, then, pain is both sensory and emotional. And then there's this resembling actual or potential tissue damage. Really, when you think about that, it's really quite profound that you don't have to have actual quote, quote, damage. If there's the perception of damage, that alone qualifies as pain. We could spend a lot of time just exploring that definition by itself because it truly is rich. And that's really what a definition like this should be: a deep representation of the vastness that is this really interesting subject that we call pain. And like so many things, if you look at it from the surface, it seems pretty straight ahead and pretty simple, but everything is easy unless you really understand it. And then the nuances and the complexity begin to reveal themselves. There are 3 broad types of pain: nociceptive pain, which is pain that's, if I am walking on the beach and I step on something and cut my foot, there is clear damage, and that is nociceptive pain. Or if I have a gallbladder inflammation, that kind of stuff. Neuropathic pain is something very different. That is pain related to the damage of peripheral or central nerves. So, for instance, I just came from the clinic, and the last person I saw is someone who had radicular pain. And so that would be under the category of neuropathic pain. The third category, which is honestly relatively new, although it's been around forever, but just putting it as another type, is this thing called nociplastic pain. And that is really interesting, especially applicable to those of us in this profession of massage therapy, or broadly, those of us who treat musculoskeletal pain, because that is probably a great percentage of the number of people that we see in our daily practice who present with pain syndromes that don't really visualize well with traditional imaging. And that's really the definition of nociplastic pain. So here again from the IASP, pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage. So, for instance, I live in Champaign, Illinois. It is the home of Dr. Lauterbur. Dr. Lauterbur is the person who invented the MRI. And maybe someday I'll tell you some really funny stories about those early forays into that. All I'll say is those magnets are really strong and things can happen. So we could see what has never been seen before. The only thing is, if you're seeing what you've never seen before, you also don't really know exactly what that means. So we could see into the tissue and see what we think are disruptions in the tissue, but only later did someone think, quite brilliantly, Maureen Johnson was one of those people, to use MRI to look at people who have zero symptoms, and often you found the same sorts of things. However, just because a practitioner can't see it doesn't mean a patient doesn't have it, right? So nociplastic pain gets really interesting and multi-layered, because if I see Whit and he is my healthcare provider and he shows me some image and says, there it is, that's your pain, I feel very validated in that. And it's like, okay, this all makes sense. But if there's nothing that shows up, you kind of lose that sense of, well, then where is it really coming from? And that is a little less satisfying. And unfortunately, it really comprises a great majority of the number of cases that people who treat musculoskeletal pain present with. So, these categories are really nice. Oh, if the world only fit nicely into these categories. But alas, in real life, in clinical practice, oftentimes you'll get a mix of all three of these. And so understanding them clearly helps you understand when they kind of mix together in a bit of a Venn diagram, really. Now, when we say pain and you're reading some article on it, you're going to see the word nociception. And that is important because it's important not to use those words interchangeably. And I know that sounds a little bit like a semantic thing, but it's really not. They really describe different things. And I have the picture here of like a home security system where the sensors are there. So it really is a pretty good example of this, because nociception is really just picking up a signal, just like those sensors will do. Hey, something just happened. And then it will send a message to like central control, in this case, maybe to me, and it'll send a message to my cell phone and say, hey, the slider just opened on your basement walkout door, and then I look and see, well, yes, I get it, but what does that mean? And if I have video cameras in my house, I can then pull up on my phone and see, hey, oh, my wife is home and she's doing some work in the yard. Very cool. So nociception is just sending the signal that something happened, but pain is the perception in the brain of, yes, but what does that mean? So the unpleasantness that all of that we ascribe to pain, that is really something that happens not through the process of nociception, which is really chemical and electrical, but it really happens in the mid regions of the brain, which also happens to be where our emotions are experienced. And that's a really important thing. And here we go back to pain, a sensory and emotional experience, because when you put someone in an fMRI scanner, this is that measured blood flow in the brain. When someone has pain, there is no one place in the brain that lights up, but those parts of the midbrain that also deal with emotions are certainly parts of the brain that light up during the experience of pain. Now, you can actually, like with any sensation, you can dial it up or you can back it down a little bit. And what are the factors that would do that? So in turning up the volume, there are two broad categories of this. One is called sensitization, And that's when nerves become oversensitive, they respond to even like kind of an innocuous stimulus as a potential threat. I bet you've all had mornings like this, right? Where just everything you could imagine went wrong. The dog left a night deposit on the carpet, and then you realize you're actually out of coffee, and then you get in the car, and then you realize, oh, I forgot to fill the car up yesterday. I don't even know if I can make it to work before I run out of gas. And then you get to work and somebody asks you for the simplest little thing and you just blow up at them. I think you might be a little sensitized, and that's what people say, right? Boy, Whit's a little sensitive this morning, right? So that's what happens when that process of sensitization happens. And physiologically, that can happen in two ways. It can happen at the peripheral level, and it can also happen at the central nervous system level. They're slightly different, but both parts of the same kind of principle of sensitization. So in peripheral sensitization, a really good example is you screw up, you forget to do the sunscreen thing, you end up with a sunburn, and then you've been at the beach and feel a little grody, and it's like, man, I'm going to jump in the shower, and you set the temperature for what you normally set the warm water at, and then the water hits your shoulder and you think you're going to die, because the peripheral nerves have been sensitized by that. And so the heat, which normally is like, oh, I can feel that, that's a little hot, is now just overwhelming. So that's kind of a crazy, exaggerated example of peripheral sensitization. But you can imagine anytime you have an injury site, peripheral nerves are going to ramp up their sensitivity level and then over respond to things that normally wouldn't bother you. Part of the process that happens in this is something called wind up. So you can have a stimulus, and it depends really on frequency, not so much intensity, but the frequency of how these things happen. I put this little image down. You see the guy poking the other one. So imagine that Whit and I are at the next IMTRAC conference, the International Massage Therapy Research Conference, and we're sitting together, and I just poke him one. And Whit's going to look at me and go, what? What do you need? Right? That's fine. But if like every 5 seconds I keep poking him, he's probably going to turn around and whack me, right? Because it gets successively more irritating. So a stimulus that just keeps happening over time just keeps ramping up the sensitivity level until you get to a point where it's just over the top. And you can imagine, as those things can happen emotionally, where one event happens after the other, like the morning I described, or that can also be just straight out physiological thing of unrelenting discomfort that just keeps pushing the baseline level up. And when that reaches a certain point, I bet all of us therapists have done this thing where, the client might say, that's a little too much pressure. And your brain goes, oh my gosh, I was just putting on the lotion. Like, wow, this person is really, really sensitive. That sensitivity, where just honestly touch is perceived as pain, there's a name for this. It's called allodynia. And that's that kind of exaggerated response where you have this lowered pain tolerance, so much so that, again, just touch alone will do that. And there are several conditions where it's kind of like pain just totally gone awry when that happens. And this is really an egregious example of how that pushes. But honestly, in the clinic, you'll see this quite often, that people are hypersensitive to what should be just touch. In the central sensitization aspect of it, this gets really interesting, where when the central nervous system is lit up, everything downstream of that is then also lit up. And I have the additional chart here is the tender points of fibromyalgia, because fibromyalgia is a really good example of what this means. What we understand about fibromyalgia now is that it is really an overactivity of the central nervous system, which then creates like allodynia and supersensitivity through all these spots. If you look at actually the history of these, tender points, there were all these different people who came up with different tender points. The bottom line is it's kind of like tender everywhere. It's not so hyper precise as you might make it think, because there are multiple practitioners who all came up with different reference points. I think the larger picture is it's kind of allodynia. That's what we're talking about, systemic allodynia. And again, when the central nervous system is lit up, downstream, everything is affected by this. And this is why you can't have like fibromyalgia in your right leg, right? It is distributed equally throughout the body, at least the upper body and lower body, and often throughout the whole nervous system. So it's kind of the poster child for central sensitization. I would say, Whit, also anything you want to add, please jump in, okay?
Yeah, absolutely. And this is an outstanding sort of overview of a lot of these things that are going on here. So, and especially this point here about this being so global that you don't get fibromyalgia in your leg. It's a really good point that this is a central factor.
So then, and that's important for us, because to treat it then, local treatment is not necessarily going to be the thing that would make the most difference. However, to that point though, the idea that it's top down only, it's top down and bottom up. And again, I just came from the clinic, and one of the people that I saw, she had a spinal issue that was then cascading, in her lower extremity. But it's not like if we solve one, then everything below it will then magically resolve itself. That is the height of ridiculousness. Doing a top-down, bottom-up strategy just makes the most sense, because the information goes both ways, something that I know Whit is going to talk about a little bit later in the presentation. And boy, oh boy, we could spend a lot of time with this. I'm going to control myself here, but just this idea of this interesting cycle of pain and stress. So pain itself is a stressor. I mean, no kidding, right? Like, of the most incredible kind. I mean, when you're under pain, that is a severe form of stress, and that demands resources, which is going to leave you with less resources, kind of the neurological bandwidth to handle the rest of life. And then that's actually going to, so that each one just plays off of itself. So imagine you have this pain, and then like for instance, let's say I have this pain in my wrist. Now I'm thinking, oh my gosh, I make my living by seeing clients. Maybe I won't be able to see clients. Oh my gosh. And then pretty soon I'm going to lose the house. And then my wife is going to divorce me. And so pretty soon, in short order, I started out with pain in the wrist, and now I'm homeless and single, like, wait a minute, how did we get to that? It's just the way those two things kind of play off of each other. And this is most often true, honestly, if you look at the literature with musculoskeletal issues. And part of it too has to do with money. In our healthcare system, getting sick is not a good thing for your livelihood, right? And for most people, and the data about that is pretty scary, actually. A lot of the population lives one paycheck away from, having a healthcare crisis and then having a severe financial aspect to it. So you can see where these two things just really play off of each other. We could spend many hours just in that domain. Whit, I want points. I'm going to leave it at that.
Okay.
And when we look at this, we'll do the same. We often talk about the biopsychosocial. The cool thing about our work in massage therapy is that we really have the potential to influence all three of these. I have to say, in this presentation, in the context of this, and with the time that Whitney and I have, we're not going to deal with the biological, which we could spend a fair amount of time with. We'll focus a little bit on the other two domains, And those tend to be the psychological and the social, but certainly the field that we do, the work that we do, addresses all of them. If you just take for instance, on a psychological realm, fear of movement, isn't it interesting that if you look at, the broadest two types of pain are acute pain and chronic pain. If I have an injury to my foot, I step on something that's sharp and I cut my foot, it's going to tell me, okay, buddy, you need to stay off your foot for a while. Okay. So what is completely appropriate for acute pain turns out to be disastrous when applied in the long term for chronic pain. Nothing is more a better example of that than kinesiophobia and back pain. If your back hurts, you just feel like, well, if I move more, it's going to hurt it more and I'm going to create some real damage. And there's really very little evidence to support that idea. But if you come from the acute pain reference point of, I just need to rest it, it's not going to go well for you. In the old days, it was, for back pain, it was bed rest. And that is like never really prescribed anymore because the outcomes are so poor. So, but it's understandable why we have those things, but this is one of the hurdles that we have to surmount.
Doug, I was just going to say one other thing too, just to jump in here, that one of the other things that magnifies this kinesiophobia is you have reinforced experiences. If you do something and it hurts, then you are going to naturally think the next time I do this, it's going to hurt, or it's going to hurt worse. And so those tend to be sort of like your earlier self-perpetuating cycles around stress. I think the same kind of thing can happen with mechanics and the pain that people feel.
Great point. Absolutely great point. And the bizarre thing is just, we'll talk about this later, but when our motor system is called upon, like if your knee hurts and you're being chased by a bear, your knee will never have felt better, right? Because your nervous system knows, okay, they're moving. I'm going to ramp down the nociception, the pain response, because it doesn't really help for survival, right? And so the more you move, actually, the better you will feel. But you can see where that conflicts with this idea of maybe I just need to not do this anymore.
Just for the sake of clarity too, for our webinar,
Yes.
to let people know that the recommended reaction if you're around a bear is not to run. just so they don't get that from us.
Okay.
Everyone who's ever lived in bear country will tell you, do not run from a bear.
Okay. Well, in Illinois, we just, okay,
point.
Never mind. Okay. All right, Whit, I'll change the slide. Oh my gosh, too funny. So, with pain, it's not just what you feel, it's what you think it means. And it's I was kind of describing with my, hurting my wrist and thinking, oh my gosh, I'm going to be homeless and, and my wife's going to leave me. It's not just what you feel, all meaning goes into that in a really big way. And one way to look at this too, like, if I have an x-ray of my back, I'm 67, and I can tell you, if you take an x-ray of it, you are going to see degenerative changes, right? But it does not mean that degenerative changes are the reason I might have back pain. And for instance, if I have some back pain, I've had an x-ray and I think, oh my gosh, I've got degeneration in my spine. And then I see Whit, and then 3 sessions later, I'm actually 80%, having 80% less pain, and I'm doing things. I'm pretty sure that the x-ray looks the same now that as it did before. But the difference is I now have hope that actually there's something that can be done about this. And that is a really important thing that we can give people. Is it matters to what you attribute your pain, and especially if you feel like it's something you can do nothing about. And that's this idea of self-efficacy, that people have some control over the process. Honestly, I don't have much control over degenerative changes in my spine, but if it's something a little more musculoskeletal in the sense of like soft tissue, that's something that we can do something about, and that gives me hope. And I think for a lot of people in pain, they just feel like they've lost really a sense of control over their life. And when you have better control, you have much better emotional regulation. And this is this tie between pain, stress, and emotional issues. And I have this little mouse here. It's really an interesting study in stress when you stress mice and they have the ability to control the stressor through pressing a lever, the stress level just plummets. And what's interesting is when you disconnect the lever and it doesn't work anymore, their stress level still goes down because they feel like at least they're doing something. Man, there are profound lessons inside of that. And Whit, I'm going to turn it back to you. But I'm two quick things here just about the social dimension of pain. I think it affects us in a couple different ways. One, your sense of autonomy. If I'm in pain, I feel like, yeah, I've lost my ability to be that person who can take care of myself, and that's a struggle. And then the flip side of that is it's also my need to belong to a group. If I'm someone who struggles with migraines, and Whit says, "Hey, you want to come over for dinner? Come join my wife and I on Thursday night." I feel like, should I say yes? Because what if I get a migraine, then I have to turn them down, and then I'm wishy-washy about that, and I always say no, and then pretty soon Whit just doesn't ask anymore. And what happens is social isolation. And boy, the conundrum with this is people in pain often feel and are isolated, and the more isolated they are, the more pain they are in. Oh my gosh, here we go with that cycle again. So there's some data on the screen to that effect. And the bottom line is pain and social isolation go hand in hand in really devastating ways. So
Yeah.
let me stop this and switch, and Whit has some really great info to build on top of this.
Yeah. So, Doug, thank you so much for that introduction to the those concepts about pain, because I think that's a really important place to start, is understanding what we're really talking about when we talk about pain. So what I want to do is transition a little bit and talk about the landscape of how this is dealt with and interpreted from a research perspective and a practice perspective a little bit in terms of how some of these things impact us. So one of the places I want to start with, everybody remembers the saying from the Apollo 13 movie, or actually it was from real life, when the Apollo 13 astronauts were reporting back to their NASA headquarters that, we've got a problem indeed. And I want to highlight something that does not get talked about a lot in relation to how this whole landscape of pain and pain research plays out. And a lot of this has to do with the education. I'm going to go backtrack a little bit in terms of education of how we learn about pain and musculoskeletal disorders, because a lot of the processes that we learn about and a lot of the ways in which this makes its way into clinical practice has to do with how things are set up in medical schools and how that information and that practice is then translated. And interestingly, we've known for quite some time that there are some significant educational deficiencies around musculoskeletal medical training in the medical schools. And this has a lot to do with, then what happens to the patients when they're coming into practice looking to get help with these things. Roughly 20% of physician office visits in this country, in the US, are for musculoskeletal disorders. And the thing that's fascinating about that is that this came from a recent study that had been looking at, what was going on with the medical school curriculum. And they found that less than 15% of the medical schools in the United States had mandatory curricula around musculoskeletal problems. And that means really that there is a huge gap that appears out there. And we see this gap appearing in the healthcare system in terms of who is prepared to deal with a lot of these pain complaints that we're faced with, and who's accurately identifying them and recognizing what they are. And for that reason, I think a lot of these people end up in your treatment rooms, mainly looking for help because they have not gotten it elsewhere and they have not gotten appropriate care, or somebody told them, hey, massage was great for me. Why don't you try it? It'll help you as well. And so these people are getting referred to us. And that is why we need to have a better understanding of what goes on in the bigger picture about pain complaints. But let's talk for a moment just again about what has been done. What is sort of the research indicated so far about moving forward on this sort of thing? These are some of the areas that we have done research studies around massage and its potential benefits in addressing a number of these kinds of problems. And that's always beneficial because you want to know, where have we started from and where is this potentially going to take us? So these are some of the areas that we have looked at specifically. Now, obviously, granted, there's a whole lot of other things that really need to be studied. And I want to call, attention back to something that Doug was talking about earlier too, which is that, when you have a lot of these nociplastic pain problems that are, I don't know what's going on. I just hurt all over. I don't know what this is, conditions like fibromyalgia or some of those other widespread systemic problems. It's a lot harder to do some of the specific research studies on them that are looking at a particular technique or a particular tool or methodology, because we don't oftentimes know exactly why some of these methods work, like exactly why massage does some of the things that it does sometimes. So that is one of the things that does make it a bit challenging. But we also want to know from those studies that we have done, can we extrapolate those findings into other things? Like if we've got a study on carpal tunnel syndrome, can we take that same study and extrapolate those findings for somebody who has tarsal tunnel syndrome or somebody who has, tennis elbow, or what other types of problems can we take? And that really means looking in detail at some of these methodologies around the ways the studies have been done, because granted, as we know, there are some particular challenges and problems with what's done in massage therapy research for how accurate it is and how much we can extrapolate some of those findings. So some of the things that make it challenging for us to take the pain research into our realm and look at it have to do with, for example, there is a big lack of funding around this area. And this is one of the things that the Massage Therapy Foundation has been trying to address, of course, by funding research studies that have direct relevance for what we're doing. But, if we were selling some kind of pharmaceutical intervention or something that was going to make a lot of money for somebody, it would be a lot easier for us to get funding for a lot of the research that we do. But because we don't, then it isn't so easy to get that kind of funding. We also have to look frequently at the study methodologies, because there's a funny sort of story or sort of relationship thing about how when we look at what is actually studied in many of these methodologies, there's a parable about a guy that's a sort of drunk guy looking for his watch on the street under a lamp, and somebody comes upon him and says, "What are you doing?" It's like, "Well, I'm looking for my watch." And he said, "Well, did you lose it here?" And he goes, "No, actually, I lost it down the road there." And he said, "Well, why are you looking here?" And he said, "Because there's a light here." And oftentimes with study methodologies, what we end up studying is what we can easily measure. And that may or may not always be the best marker of, are we identifying those things that we really need to focus on for identifying the accuracy or benefits of massage. Another big strategy or problem that we have is this incredible variability of techniques that we use. I think in the recent ELAP project that was sponsored by the Big Seven organizations, they were trying to determine how many different modalities or techniques are out there that we need to teach massage therapists about. And one of the things that we did they did identify out of that process, I can't even remember the number, but it was somewhere like upwards of 275 or something different techniques and modalities out there. So when we're studying pain and studying massage for pain management, do we study, this technique or that technique, or how much does the technique even matter? I mean, there've been a couple of studies that were even looking at this question of, does the technique matter, or is it just really the ability to do something beneficial and some type of therapeutic touch intervention for somebody that really helped them the most? The other thing is, it is very difficult to get consistent applications of a particular treatment strategy in massage, because we so individualize our treatments. And we could do this in our research strategies, where we say, okay, we're going to try to see, is massage beneficial for people with migraines if we do 10 minutes of petrissage on their neck exactly this way. And that would be the best way to get a consistent research result of a consistent application across all the individuals. But let's face it, nobody practices like that. You treat one person differently than you treat another person. And so we don't always know if we're getting that same degree of consistency in terms of how we apply those things, and that makes it particularly difficult to study. And then lastly, this whole idea of placebo responses, and this is perhaps one of the most very powerful things that we do with our massage treatments is the use of placebos or what comes out of placebo responses, which is essentially the very act of being in a therapeutic process in a therapeutic environment with somebody has incredible therapeutic power. And Doug was referring to this earlier, just being in that treatment session with somebody and just the very sense of being there and having somebody care for them compassionately and touch them in a compassionate manner has a lot of therapeutic potential. But a lot of times we try to rule that out of the study so that we can measure what is supposedly the real things that are happening. But this is something we really need to be focusing on and paying attention to, because it's an important part of the process of what helps people get better. So some of the other things that we want to look at here is like, what are some of the models that might be used with integrative care to kind of help people more appropriately, look into how these things are most effectively applied, or what kind of environments might we be doing them in. So we could, for example, look in various types of rehabilitation centers. We see massage being used for pain management in a lot of these things. And I certainly hope there's a wave in the future that's going to see even more of that happening. Lots of folks are doing this in private clinics. And Doug, you've got a masterful clinic there with a lot of people working in your clinic doing a lot of this kind of work. And in fact, this is probably where the vast majority of massage therapy, pain management clients are arriving, is in individual private clinics. So this is something that we need to kind of study a little more carefully and see what kinds of things people are doing in those private clinic environments. We also see it done a lot in places like hospice care, or end-of-life care, geriatric places where people are doing predominantly palliative care types of treatments. These are beneficial things that they can do there. We also see it a lot in manual therapy clinics, pain management clinics, PT clinics, chiropractic offices. These are all locations where we might potentially see these things being done in a variety of different models and a variety of different methods. They're all places that we could study this more specifically and find out what's going on here. So these are some of the things that we can focus on and look at the benefits of how massage can be utilized most effectively in these variety of these different environments here. So Doug, I'm going to turn it back over to you now to jump into some other aspects of our pain evaluation.
You bet. Thanks, Whit. One of the things too about that, just in terms of the studies, I think that's really important. But to everyone out there, I would say it's important to remember that all formal research studies had their birth in an informal observation. So this is where case study kinds of things come in really in a really important way. If there's something that you're doing in your clinic that you find quite interesting and quite helpful, taking the time to write it up, to share that. Formal exploration came from informal ideas first. And that's really important for all of us to remember. If we look just at the burden of pain to the economy, to people, it is staggering. When you look at between 2019 and 21, that prevalence, really 1 in 5 adults in the United States are in chronic pain. Good grief, that's a lot of people. And remember, there are real people behind those numbers. The cost to the economy in 2021, probably the data for 2022 will be coming out soon. It takes a while to aggregate that data. But, we're talking about $460 billion annually. And the greatest expense is in the musculoskeletal side. You'd think it would be, there are many other things, right? Like cancer, heart disease. But actually, musculoskeletal pain is the most expensive cost to the economy. So to Whit's point earlier, there are so many people who are struggling with, and it affects them in every aspect of their life. And it's not just in the United States. This is really a global issue. So much so that between 1990 and 2020, the incidence rate went up 123%, and the projections are between 2020 and 2050, the next 30 years, it's going to go up 115%. So if we're so good at this, why are the numbers so bad? There is so much work to be done. And again, so few people actually addressing this. And if you look at, for instance, just in the research realm, again, I actually looked up the numbers of how much money was invested in the research realm in, for instance, looking at cancer versus looking at neck pain. The numbers are staggering, like $7 billion for cancer research, which I understand. But in neck pain from NIH, I think it was 2016 or 2018, it was less than $1 million, less than 1 million compared to 7 billion. So I understand that people don't die of neck discomfort, but when you look at the economic impact of this, it is massive and needs to be addressed.
Doug, do you think, just out of curiosity, do you think that is related to that point I was bringing up at the beginning about the lack of curriculum content in medical schools around musculoskeletal disorders playing out in terms of what's spent on research and focus on these?
It would be hard not to see that as a factor with, and as you know, I every year I guest lecture at the University of Illinois Medical School, and I have a little bit of knowledge of how much time they spend on musculoskeletal issues, and it's very little actually. So it's hard not to imagine what those two things aren't connected.
Yeah.
And when we look at this, I mean, as someone, I think it was General Bruckenmeyer at one of the MTRAC conferences from the Massage Therapy Foundation said, we don't have a pain crisis. We don't have an opioid crisis. We have a pain crisis, excuse me. And I think that's really important. I put a red arrow by this. 1.6 million people misuse pain relievers for the first time. And this is 2019 data. It's worse now. Seemingly, as much as we know about this, the problem just keeps getting worse. But overwhelmingly, the people who struggle with opioid addiction started with a prescribed opioid first. Overwhelming majority of people who go down that path started first with a prescription. This is really scary stuff. And most of those prescriptions, the most common reason is a musculoskeletal reason. Here we go again. So here's just a graph of overdose deaths in from 1999 to 2021. And again, the data I've seen from 2022 is above that, and that's because of fentanyl. So scary stuff, actually. It's really interesting that the AMTA funded this study from John Dunham and Associates. This was published in 2018. They shared the results of the study, but just, and this is what this Dunham and Associates does, is they do projections about stuff, aggregating a ton of different data, and then inputting these models to see what might the effect of this be. And their thing is that introducing massage therapy more broadly could affect up to 5 million patients, save 110,000 people from opioid disorders, and potentially save about $25 billion. Again, these are projections, but if you read the work that they put into it, it certainly will get your attention. So let me just apply a couple of things, and then I'll switch back to Whit here. But from some of the things that we talked about, what are things you can apply to your practice? As we talked about kinesiophobia before. For instance, with low back pain, as Whit mentioned, we know that movement is a really good thing for you. But again, it's really difficult to do that. Like to tell somebody in low back pain, you just need to move. Well, it's nice for you to say, but you're not the person in pain, right? And so one of the locations of my office now for the last few months has been inside and working with a group of physical therapists. And this has been a really good thing. If we can make their patients more comfortable so that movement is more comfortable, guess what? They will move more. And if they move more, they'll feel better. And if they feel better, they'll move more. And so in that way, the work that we do is such a wonderful catalyst to make movement possible. And that, in many ways, should be the focus of the work that we do, because when movement is more comfortable, you fear it less, and so you do it more. Whit mentioned the placebo effect. A few weeks ago, I had the great honor of presenting at a neuroscience conference on pain for Oxford University in England. And the session before me was a lady who was a specialist in the placebo effect. And I thought one of the things that she shared was so interesting, that the nocebo effect really has more clinical impact in terms of outcomes. So the placebo effect is when you believe something is, helpful when it might really not be. We all understand that. But the nocebo effect is where you believe something is really detrimental, but it also might not be. For instance, I look at that x-ray and I think, oh my gosh, I'm screwed. My back looks terrible. Not realizing that, well, actually somebody else's back looks worse and they have no pain at all. So that's the nocebo effect. So her point was, for clinical outcomes, work towards decreasing the impact of nocebo effects. It'll have more impact than the placebo effect. One point about the placebo effect, the very first International Massage Therapy Research Conference sponsored by the Massage Therapy Foundation that I attended many years ago, just never heard of the foundation, just went on a lark. I remember that there was a guy from the National Institute for Health who was a researcher, maybe one of the directors, who said, you have no idea the lengths in research that we go to remove the placebo effect. And he said, so I just would like to say, in your clinical practice, you should go to those same lengths to put it back in. I'll never forget that statement.
That's great. Yeah.
Yeah. So here's another piece. Massage for interoception. So what is interoception? It's that self-discovery that when I'm on the table and someone is working on my body, let's say have you ever been on the table and somebody's on your back and you think you know anatomy and you say, are you on the iliocostalis? And maybe if he's the person is like, are you kidding? I'm not even close to that. Like, how am I that far off? Or how many times we've been on the table and you kind of feel, or how many clients have said, I was fine before you started poking around, right? Like they just didn't realize what is really in the tissue. That is what interoception now is. What's really interesting is the link between interoception, the way it kind of reclarifies the somatosensory map in your brain, but also its connection to emotional regulation and depression. The people who are depressed, their levels of interoception, that their self-awareness is definitely decreased. And by increasing one, you actually decrease the effects of depression. This is really interesting. Mm-hmm. When you think about pain, the link between pain and depression is really, really strong. 55, depends on which study you look at. At the lowest number, it's 35. 55 is on the higher number of people in chronic pain also have anxiety and depression. Now, the question is, which came first? That's another issue. But the thing is, they are co-occurring. So, and what we know, what's really interesting is if you affect one, it affects the other. If you decrease pain, depression tends to be less. If you can work on the depressive thing, their experience of pain is less. So these things are constantly feeding each other. Think about that and interoception as a way maybe that we could make a difference. And there's some really nice initial evidence to that fact. And boy, do not underestimate the power of just deep listening to people. So I've been kind of knee deep in this for a little while. And in the traditional healthcare world, when a patient sits down to tell their story, they are typically interrupted in the first 11 seconds. Wow. That's not much, people just do not feel heard. And that's a really important thing. And part of it is too that we have such a poor way to convey our experience of pain. The language is really quite inadequate in describing what we feel. But all of that, what that leads to, that listening leads to, that my sense if I am the client or the patient, that person really understands me, or that gets what I experience. And boy, the power of that to create clinical outcomes is really big. So increasing everything that you can do to increase that connection between therapist and client is going to have a really positive effect on outcomes.
Mm-hmm.
And so with that, I'm going to shift back to you, if you would, sir.
Yeah. So that's a perfect segue into what we want to wrap up with in this last segment here, is really talking about, like, what do we do? Like, how do we take this information that we have and now put it into practice? So I want to cover a couple of key things that I think are really relevant here. So one of the first things that we can say is really important is what we've done so far today is this process, understanding the fundamentals of how pain works. That's where the place that you really need to start, is having a good understanding of exactly how pain is managed, how it's perpetuated, and how it develops in the body. I also think, and this is something that's been a sort of a pet peeve project of mine for the last 30 years, is that I do think a comprehensive assessment process is really important, because there are so many different potential causes of pain, and we need to sort of try to delve down and find out, is this something that might be more nociplastic, or is there apparent tissue damage here, or what really is going on? Because the way we're going to address that and treat it is going to be driven by what we find in the assessment process. Many of you may work in conjunction with other health professionals, and even if you do not have anybody that's directly in your clinic with other health professionals, those people that you see are probably seeing other people. And so we need to have a collaborative approach that looks at, how do we integrate the care that we're giving with the things that they are doing in their other healthcare applications of the other people that they're working with. And that also means showing a great deal of respect for the other things that they might be into doing that maybe you don't think are a great idea, but this is part of the collaborative approach of what they want to do to manage their own care process. So that's an important part for us to develop. I often speak about this as being a key thing here too, which is that we do two things when we walk into the treatment room with people, and a lot of us don't think about this second piece. Number one is we are the clinician that's going to work with that person and do physical tissue manipulations for them and make them feel really good with what we do with our hands. But the other thing is, everybody is an educator. As soon as you walk into that treatment room, you are also going to be educating your clients, because they're going to ask you questions. They're going to, want to know more. You are going to want to share with them some things about that are going on there. Those are really critical factors that make this therapeutic process work really well, when you can do your therapeutic interventions really well, and you can also do education really well. And that's going to help you in the long run also then monitor and adjust your treatment strategies appropriately for how you're going to address each individual thing that we're doing. So these are all key factors that you want to think about, like, how do I continue to enhance and develop and make those things better for the people that I'm working with? And I want to call your attention now back to something Doug was talking about earlier too, which is the individuality of this pain process here. I ran across this a couple of years ago. I love this analogy from Greg Lehman, who's a physiotherapist biomechanist up in Toronto, Ontario. And he talks about people come to our therapeutic encounters with a cup full of things in their life. And there may be all kinds of different things in there: tissue injuries, kinesiophobia, which Doug talked about earlier, the fear of movement, some of those biopsychosocial factors like social isolation, catastrophizing, that idea of, like, he talked about, going broke, being on his own, and, his wife leaving him and everything. By the way, I don't think she would ever leave you, Doug. I don't care how bad it gets. So, and these are all things that lead to this. And I've got this acronym in here, VOMIT, which Doug actually alluded to earlier. It's not what it sounds like, but this is an acronym for a victim of medical imaging technology. So these are the people who may have seen those scans or those x-rays, things like that, and then made an assumption that that was indicative of a real serious problem that they were having that they needed to get addressed. So keep in mind, when people come to see you, everybody's bringing their unique cup full of things that might be very different, and we don't know what those factors are in each individual's cup, but we know it's a blend of different things, and that's our strategy, is to find out what's going on with them. Now, I wanted to take a moment to give a bit more of a schematic representation of some things that we've talked about earlier. I always like having some visuals about this, and this kind of helps me get an understanding of it. Doug was talking earlier about the potential for turning up the volume and turning down the volume. And so I want to delve into just a moment here neurophysiologically what's really happening there. There's perhaps, in my mind, I think the most powerful thing that we do with massage is working with the nervous system to enhance what's called descending modulation. So what that means is up at these higher brain centers, there's a capability for the brain to send signals down through the spinal cord to the lower, portions of the brain stem and down into the spinal cord that can alter the way in which some of these signals come up and get processed eventually as pain. Let me come down here for a moment to this little box right here that says ascending facilitation, because we'll start here. Doug talked about this earlier about the role of central and peripheral sensitization. So if you look at this red pathway on the screen here, so these are sensory signals that are coming in from the periphery, and various factors may cause them to be overly hyped up or overly amped up. And this is ascending facilitation. And we call it ascending because they're on their way up to being processed in the higher brain centers. So if that volume gets excessively turned up, that's what happens in the central and peripheral sensitization process. But the cool thing is we have the capability to adjust that a little bit. And we can do that in two different ways. One is this pathway of blue signals that are coming down can come and interact with those signals. And if we suspect, for example, if the brain perceives that that signal is actually not strong enough because we need to hear more about this, this is really important, it may turn up the volume on that signal, and that becomes what we call descending facilitation. It's descending because the signal is coming from the higher levels and then causing that signal to be turned up. I know that's a little bit confusing to have an ascending facilitation and a descending facilitation, but they're actually very closely tied together. But the other one that is so important that we want to focus on is the descending inhibition, because we also have the capability in these higher brain centers to send signals down here that turn down the volume and decrease the likelihood that a lot of those signals are going to eventually be perceived as pain signals or pain factors that we have to address through some other method. So the big question is, how do we get more descending facilitation happening here? And this is where I think massage therapy does probably a better job than almost any other pain management strategy that we know that's out there, because it works on all of those biopsychosocial levels, biological, psychological, and social levels. All those things are coming together to make a part of it. There's a great sort of division of these things that was described by Lorimer Moseley and David Butler in their book Explain Pain, where they talk about DIMS and SIMS. DIMS are those things that turn up the volume, and they refer to this in an acronym as danger in me, and the SIMS are safety in me. So the DIMS are the nociception, the previous experiences, expectation. All of these things can ramp up or increase the sense of pain that an individual has. But I love this over here on the other column, the first thing up here. This is a word coined by Jason Erickson in Minnesota. It's a yesiception, he calls this, which is the opposite of nociception. So what is it that helps make a person feel better? All those things that you do in your treatment room, the soft lighting, the quiet music, the scents, the aroma, the individual compassion and the care, all of these things wrapped up together produce and enhance the SIMS. And they're a big part of what makes somebody feel safer and more effective in the treatment room of what you're doing with people. And because we spend so much time with each individual client in our treatment sessions, we have the capability to maximize these SIMS better than most other people do in the healthcare professions. So in our individualized treatment plans for going through this, keep in mind there are some important factors here that we want to address. The variability in pain perception and tolerance, because people have different levels of pain perception and different levels of pain tolerance. That's why regimented recipes and routines don't work well, because people can be very different in how they experience these things. Identifying when possible the specificity and location of pain is going to be critical to identify what kind of strategies for us are going to be most effective. Is it a more generalized approach for a systemic centralized pain problem, or is it a particular pain tissue pathology because of some type of tissue damage or something that's in there? Those things are going to be key factors. We also want to think about potential diverse and coexisting conditions or any contraindications to pain problems that might prevent us from doing the treatment that we're doing, paying attention to how our treatments are going to interact with the other treatments that people are getting. So how does massage blend and impact with those other treatments? That's going to be a key factor for us to pay attention to in our processes as well. And then lastly, how does that person respond to treatment? And then how do we adjust the treatment accordingly based on the way they respond? These are all going to be critical factors for us to consider to make our treatments the most effective with everybody. The other thing, and I alluded to this earlier, there's a good deal of interprofessional collaboration that's really important. Working with other health professionals, whether you're doing this individually in your clinic or collaboratively with what that person is doing and with the other people that they're seeing. The more we learn about what other professions do, the better we can be at integrating our treatment along with them. So there's several initiatives that are currently going on in the healthcare system to try to break down some of these silos between various different professions to help us better understand the things that we're doing with each other. So these are all key factors that we want to zero in and focus on. So lastly, I want to leave you with some resources that I think are particularly helpful and beneficial on your journey of exploration into learning a little bit more about pain problems here. There's a wide array of academic journal articles on pain problems and some other fascinating aspects of this, like descending modulation and how this works with manual therapy. So utilize some of those journal articles. Many of them are free. As we noted too, there's some really good resources in the journal from the foundation, the IJTMB, International Journal of Therapeutic Massage and Bodywork. Those are excellent resources. If you're new to some of this stuff and you just think, oh, well, I'm a really busy clinician, I don't have time to do this, there are some outstanding new AI research tools that can be used to look at a particular research question like how can massage help with pain management, and it will give you academic papers specifically, and then it will summarize those papers so you can read basically in your busy clinic day even just portions or summaries of these different things, and that can give you a wealth of great information about what's going on in the pain world. There is, of course, thousands and thousands of resources on the web, from blog posts to YouTube videos to things like that. There's a lot of things out there. So if you're interested in various aspects of this, just Google the term pain resources or pain management massage, and you'll come up with lots of different things out there. There's some wonderful courses out there that people have, online and in-person courses on massage for pain management as well. So these are a number of other great resources people can do. And I know why a lot of people don't like social media discussion groups, because they can often devolve into some, argumentative discussions and things like that. But they're also a place for a wealth of really great resources and information too. So to take a look at some of those social media groups that are specifically around massage or specifically around pain management, because there are some really good ones out there that will be very useful resources for you. And then, of course, books on pain management related topics. There's a number of outstanding books and resources out there. We don't have time to really list them all out here today, but a lot of really great things that people can go and find that will be helpful for them in expanding their careers. So want to thank you again for your time joining us today, and talk just a moment briefly about some other foundation resources that we have. Adrian, do you want to jump in and talk about some of the stuff that's on the screen here, or shall I just go through and
I can pick it up from here, Whitney. I
yeah.
That your voice might be a little tired. There's a lot of information that you gave us here. Thank you so much, Whitney and Doug, for just this gift that you gave us today. There's so much here and I'm already envisioning branches of portions of this particular presentation that I know I'm personally interested in with my clientele, and I'm positive that everybody who is watching this either live or who tunes in a little bit later will think the same.
Mhm.
The Massage Therapy Foundation is where you should go to see all of the resources that we have in order to support your practice. It is because of the resources that are given to us by the Massage Therapy Foundation that my practice is thriving and my clients are really succeeding because of information like this. So massagetherapyfoundation.org is where you can find this. All of these things are free. We are able to produce these resources from the generous sponsorships and donors. So if you're watching this and love information like this, please consider becoming a monthly donor for the Massage Therapy Foundation. At as little as $10 a month, we can bring more resources and activities like this to your laptop and your cell phone. And we even have the next international international massage research conference coming up in April. So you can find all of that information on our website at massagetherapyfoundation.org. Just to give us a little bit more information, here are a few people have asked about how they can participate in massage research, and MassageNet is really the best way to do that. It's free to be a member, massagenet.org, or you can find it through massagetherapyfoundation.com. Please remember that you can earn 1 CE by taking the quiz that's associated with this. So here is the link, and we will post this on the website as well. If you'd like to learn more from Doug and Whitney directly, Doug has precision neuromuscular therapy seminars, pnmt.org. And Whitney's company is the Academy of Clinical Massage at academyofclinicalmassage.com. Thank you so much, Doug and Whitney. We really appreciate all of the time, talent, and treasure that you give the Massage Therapy Foundation. Thank you, everyone.
All right. Thank you all for having us here.
Thank you so much.